director, liked it so much she wants us to have a full kind of CCG Protected Learning Time event on it. And whether, I don't know that's going to be possible this year because our schedule is already organised, but you know, I'm hoping that we can reproduce it in CCG Protected Learning Time events, and we're really looking forward to your feedback, you know, at the end. So I know Dr. Mehdi has got to leave fairly promptly. So can I introduce? Are you going to use the mic?
I'm happy to. I don't think I'll be heard as well.
Okay, so this is Dr. Tauseef Mehdi from our CAMHS Rapid Response team as a consultant psychiatrist. Thank you, Tauseef.
So I've got the mic in the left hand and I've got this clicker on the right, so bear with me if I get confused. So I'm the consultant psychiatrist for the CAMHS Rapid Response team in Berkshire. We've been commissioned since 2016-2017, covering the flow of crisis presentations in children and young people coming into either Wexham Park Hospital or Royal Berkshire Hospital. And that's what the structure is going to look like. But due to the fact that we only have 25 minutes, I'm not going to go through all the slides, but the slides should be accessible to you. The latter half of the presentation is actually quite factual. So I'm not going to talk about that. I wanted to talk about some important messages about how we think about crisis, how we think about risk, how we think about suicide, how do we think about distressed adolescents, and demonstrate that by the work that we do and by using a case example. Okay. So what do we try to do? Since our service has been commissioned, we essentially tried to improve the quality of crisis care in children and young people. But what does that mean? Well, before, assessments were often risk assessments and discharges. We tried to do comprehensive mental health needs assessments. So they're not just risk assessments, and they take longer. The point being, because we want to identify the needs of the child as early as possible, so that what we need to do for the child, we can do as early as possible. Okay? Because it just gets worse and the outcomes are poorer. We also do a brief stabilising intervention, because sometimes young people come to us, they're in a really terrible crisis, the parents can't cope, the system is quite stuck, whether it's school, whether it's social care. So there is something called a stabilising intervention, which I'm going to share exactly what that is. We try and reduce presentations to A&E. We try and reduce more worse outcomes, like a young person getting admitted to a psychiatric hospital unnecessarily. That's quite counterproductive and harmful for a child or a young person. In actually a majority of the cases, that's something we try and avoid very hard. It's only for florid mania, psychosis, or severe untreatable anorexia in the community is when an inpatient hospital admission is quite appropriate, but everything else probably best avoided. We try and come to these events to teach, train, go to RBH, go to Wexham Park Hospital, teach more about crisis and establish better relationships. How many people are we seeing then? Our annual referral rate to our service is around 850 to 900 a year. That's been the case over the last 3 years. You can see in 2016 the figure was less, and in 2015 the reported figures was less. So maybe this is an indication that the referrals are increasing. So that averages out to about 75 crisis referrals coming into hospital a month. Ooh, okay. I was worried nothing was there. So when I mentioned the crisis stabilization pathway, what did I mean? So this is what our standard work may look like for most of our patients who present to a crisis and who need a bit of stabilization work. It starts with a presentation, then there is this comprehensive mental health needs assessment. Just to give you an idea, from start to finish, for a standard crisis assessment, it's about 5 hours. So from the time the referral comes in and the clinician takes the referral, looks into the case notes, liaises with the community care coordinator, commutes to the hospital, spends about 90 minutes to 2 hours with the family. agree a discharge plan, come back, do all the administration, paperwork, liaison, follow-up, appointments, all that stuff. On the best of days, it's about 5 hours. The cases that I get involved in are more complex. Those are the only cases I get involved in when the situation is pretty bad. And I think for me, it's about 6 to 8 hours. It probably takes a day from 9:30, a mental health act assessment or a ward assessment, to get over there, assess, make sure that we can do what we need to do in terms of a multi-agency care plan, or if it's a psychiatric hospital admission, it could take about 7 to 8 hours. So that's for one case, just to give you an idea about the time that it takes to respond. Another point to note that this is crisis work, so the times are longer. Community CAMHS clinic assessments are about, on average, 90 minutes, and then about 90 minutes to do the administration and paperwork as well. It's different from adult mental health services where you have 60 minutes. So it just gets longer and longer. Anyways, but that's what it means to be comprehensive. What do we do? After the assessment, I'm not interested in jumping to therapy or medication or doing too many things. Because the first intervention is to establish the best understanding of this young person's mental health presentation. That's not no intervention, that is an intervention. Because with a young person and the parents, we need to establish an understanding that they can buy in, that they can believe in, that makes sense to them. There's no point in us telling them this is what's going on, this is what needs to happen, if they do not believe in that. Okay, they won't follow advice, they won't engage, the child is not going to get better, the risk is going to remain the same. So we call that co-producing a formulation, and that's an intervention, because that gets the young person and the family to really engage and get motivated. And once we have that, then the likelihood of them doing stuff is increased, and then we can actually make a difference and alleviate their risk and treat their mental ill health. But we don't stop there, because often in crisis we have the need to involve education and the need to involve social care. And I'll show you exactly what that looks like. When I say those things, I'm going to show you exactly what that looks like in the next slide. But again, we need to align the network involved in the care of this child with that understanding. There is no point if a social worker may be communicating something else, like your son needs to be admitted into psychiatric hospital, whilst we are saying, no, this young person does not need to be admitted to a psychiatric hospital. That's just going to perpetuate the problem. It's not going to make sense. So it's about aligning the network in a multi-agency meeting. So after the assessment, there's usually a multi-agency meeting. That could be the next day, or that could be within the 2 weeks, depending on the complexity or the situation. And again, it's aligning everybody to the understanding. Then we agree a multi-agency package of care. That means education staff doing a list of actions to meet appropriate needs, social care implementing a list of measures and supports to meet the needs, and then CAMHS doing a set of actions to meet the needs. Yeah? Once we are in that position, we're in a very good position at that point, and then there is something called a stabilising intervention that we as health professionals do there. And I'll show you in the next slide what that exactly looks like, okay? And then we hold ourselves to account within 2 months or 6 weeks. We come back all around the table, 7, 8 people in the meeting, and sort of say, has it worked? Has this made a difference? Are we on the right track? With the family, not without the family. We want the young people to come into the meeting, maybe not for the whole meeting, but maybe at the end. So we come back and then we say, is this working or not working? And then at any point, we're also thinking about long-term care, because it's pretty obvious at that point to me that this young person might need long-term family therapy or therapy or psychotropic treatment. So I'm thinking about making sure that the appropriate specialist community team have got the referral so that the clock starts as early as possible, not at this point or not at this point, because that could be 6 weeks down the line. Yeah. So what does a stabilising intervention look like? Right. So as I said, it is an intervention to correctly identify the needs, to have a joint understanding with the family, but not only the family, with social care and with education. And I'll demonstrate that through a case as to what we mean by that. Those are the first interventions. As I said, that's number 1 and that's number 2. Once we have clarity over that first, then I can initiate psychotropic treatment to stabilize, whether that is an antidepressant or whether that's an antipsychotic to target agitation, irritability, pseudopsychotic symptoms, antidepressant to target anxiety and depression, which might be underneath some of these challenges, or just for symptoms. And then our service have clinicians who can offer CBT and DBT informed supportive sessions, which we can offer once a week or once every fortnight. And that offers a bit of containment and a bit of safety work and a bit of education and a bit of risk management, so that the young person doesn't have to self-harm anymore, doesn't have to take an overdose or burn or abscond or take drugs. Yeah? Dialectic behavior therapy. It's CBT is cognitive behavior therapy. DBT is something which is very useful in young people with emotion dysregulation and repeated self-harm. So when I mention a multi-agency package of care, we call it a needs-led multi-agency plan. Yeah. So in this particular case, this was a recent case that we dealt with. You can see on the page that we've got social care, education, police, and CAMHS. And we sat on the table. There was 12 of us. Social care, allocated social worker, child in need plan, provided a family group conference, social work visits in the home setting, family and behavioural support, and a youth worker. Quite a bit, which was fantastic. Education offered an educational psychology assessment, a reduced timetable, pastoral support in school, and ongoing liaison and support to the family, which was fantastic. Police offered psychoeducation and something called the Willow House Project. I'm not exactly sure what that is. That is basically to make sure young people don't drift into crime or antisocial activity. And what did we do? We initiated antidepressant treatment and regular reviews, follow-ups with myself, and then sessions so that this young person was having some ideas and support and strategies to think about alternatives to self-harm. So that is a multi-agency care package for one case. So I hope that makes sense. I'm going to move on to how do we think about crisis. I'm going to keep reminding ourselves that that's the question we need to ask when we go forward. So, and we'll look at a case. We'll look at a case for that. So we've got and again, this was a case in 2019. It's a 16-year-old girl. She came from a pretty professional family. Both parents are professionals. Both her elder brothers were high achievers, sporty, athletic, all on track to university and pretty decent careers. This young girl, it just felt like she wasn't similar to her brothers, I suppose, in one sense. I mean, there wasn't any motor or language delay. However, she was described as a jumpy, boisterous, and a fearless child. Primary schooling, private throughout. Average, below average attainment. Tested for dyslexia, borderline outcome. Parents told us that there's long-standing reports of behavioural and emotional difficulties, unlike her brothers. And there's also some reports of social and interpersonal difficulties. She started to get unwell for the first time at the age of 10. She was in year 5, and then year 5, year 6, her symptoms just then gradually increased. It looked like it was mood swings, stress, irritability, anxiety, kind of a mixture of symptoms. First referral to CAMHS in early 2016. They identified distorted body image, distorted body image, and some disordered eating, purging, but she felt that things were under control, family were fine, they didn't accept any further input, the case was closed. They came back in early 2017, this time there was more severe symptoms of eating disorder, purging, diet restriction, binge behaviours, also symptoms of other things like anxiety, panic attacks, low mood, hair pulling, emergent cutting, irritability, worsening behaviours at home. What happened in 2017? She was then referred to CAMHS. She was assessed by the eating disorders team, and then she was offered a care package of once or twice weekly meetings. But her condition deteriorated. She lost further weight. There was purging and laxative use that continued. There was excessive exercise. She collapsed, unfortunately, and had to go in momentarily in Basingstoke Hospital. She gets depression diagnosed in June 2017, fluoxetine initiated, but her behaviours, her presentation is just escalating. It's getting more risky, more unpredictable, absconding, wandering at bridges, self-harm and suicidal sort of threats and behaviours. September 2018, she's getting ongoing support from the eating disorders team, nursing input, psychotherapy input, medical input, but her condition just deteriorates. 2018, continued weight loss. She gets admitted into an eating disorder unit for 3 months. She gets stabilised to a degree and comes out in May 2018. From May till December 2018, she gets a package of care that looks like individual therapy, family therapy, medications, medical reviews, liaison. But she's not getting better. She's just continuing with ongoing symptoms as well as difficulties. She missed a lot of school as well, so the level of impairment was quite significant. She missed a whole kind of majority of the year, and she had to do that again. It led to a point when she, in a fit of anger, she threw boiling water at her mum after an argument. She wanted to have a party, not having boundaries, and there was carriage being boiled, she threw it. Police were called, she was arrested, parents decided to pursue charges. She couldn't be taken back home. She got into a sort of supported care accommodation homes for a couple of months initially, then another couple of months she was in a different place in North London before she was in Portsmouth. I thought it was pretty terrible for a 15, 16-year-old who's kind of shunning around odd sort of care home placements. She comes back to Wokingham, goes into a foster care home with a plan for her to be reintegrated back into her family by summer. But before that could happen, she presented with an overdose, a major overdose, in Royal Berkshire Hospital. And at that point, parents felt that, look, we just can't take our child home, we can't manage her. Yeah? Foster care was, I don't think I can manage this child, I can't. This young person is too unwell, too suicidal, too disturbed. Needs to be admitted to a psychiatric unit, obviously. She did have a mental health act assessment, and I wasn't involved, but she wasn't detainable, and I was relieved, because I didn't think when I looked at the case note that she should be detained and taken to a psychiatric hospital. She would have been far worse, in my opinion. So we're on the ward, and then there is social care who are taking the young person and the family to the family court so that they can apply for a permanent care order, and then she can go to a secure children's home. I think that would have been a tragedy. That's really unfortunate. But what else? Where else? What else can happen for this young person? So the judge asked for a reassessment, and that's where I got involved. And I sort of came up. I was asked to do a fresh assessment, so I had to just start from scratch and look at the case and see her, speak to her, talk to the parents. And then I did change or adapt the formulation. I'm going to say a little bit more about that. Why? Just a quick question. I'm not going to go into it for too long. Why do you think nothing was working? She had a lot of support. Any guesses? There was some questionable incidents of getting involved in sexual activity, but for a 15, 16-year-old, it wasn't thought to be sort of to the level of abuse or exploitation.
Did she have any other undiagnosed underlying problem, such as autistic spectrum or
Why do you say that?
attention deficit or
Yeah.
something? It just feels as if there's something else going on.
Okay. So yes, I think the answer is yes. That's what it was. She did have an assessment actually by a private service. They found autism traits. They also diagnosed ADHD. They also confirmed that there was an uneven cognitive profile. That we would call that as a combination of neurodevelopmental difficulties. And she presented with escalating stress at the age of 10, and that stress continued to escalate and presented itself in a mixture of mental health symptoms like anxiety, low mood, self-harm, distorted body image, eating difficulties. Her presentation didn't fit a standard pattern of depression or anxiety. That was obvious. So we had to change the way we see her, and that's what we did. ASD, ADHD, cognitive deficits, these are not episodic difficulties. These are developmental vulnerabilities that are present in us since we are 3, 4, 5 and onwards. They're there every day. They are there longitudinally. They cause stress in every child. Full stop. They cause more stress in every child. Full stop. That stress is not one-off, it is cumulative. So it's there every day. You can't escape education, you can't escape homework, you can't escape going to school. So every time you have to pay attention, it's pretty annoying, it's pretty frustrating. It's not something that people look forward to, especially if you have inattention problems or if you have dyslexia. So that is cumulative stress that builds up. And when does it start to overspill? You come up to a combination of stresses. Adolescence, stress levels goes up anyway because of the rapid neuronal maturation, the increase in social and emotional demands, the adolescence, a lot of things peaking at the same time, and we're not surprised at the age of 10 and 11, when she's at that peak, that she has an escalation of stress which she can't cope with, and it starts to present as symptoms. So that's the type of conversation I'd be having with the family and with her, and luckily the parents bought it. The buy-in from the parents was there. So they agreed to take her home on the provision that we could do something about that. So, so when you said there's something which is missed, something which is undiagnosed, I've got a few more slides on that, but I'm going to come to that in a second. So what we did was we shared this with the parents, we shared this with social care, we went to court, shared this with the judge and everybody, and in a report as well. We said that this is how we think we should approach the situation, and everyone was like, okay, let's do that. Because parents were like, let's take her home. So for a child at the edge of secure care, which would have been a tragedy because you had very reasonable and caring parents, to parents saying, I'm going to take my child home, was fantastic, was the right outcome. So what did we do? We actually addressed the underlying cause of stress. We targeted ADHD treatment because we needed to help her regulate herself better, improve her attention, reduce her impulsivity. We had to do those things because that was ongoing since she was 4 and 5, and that's remained ongoing. When we're cracking on with treatment, with aripiprazole, with fluoxetine, with therapy, with medications, she's not getting better, okay, because she's not had ADHD treatment. Yeah? In parallel, the psychotherapeutic approach was adapted for emotion dysregulation as opposed to anxiety or depression or eating disorder. And that's individual and family therapy, so we gave them appointments straight away. And what happened in the next 6 weeks? They came back to see us. She was back at home. The family strain disappeared. She was adhering to boundaries and curfews. The parents were happier. She was happier. Her impulsivity disappeared. Parents tasked her to actually wash her car for 45 minutes, and she started and finished that thing. And they said that she also actually paired socks for about 45 minutes. And parents said that she's never been able to do that in her life, ever. So she was able to do those things, which was fantastic. I mean, our guess about what was behind all of this was successfully treated, and you can see the result. There was a huge improvement in impairment. She started looking for jobs. She enrolled back in college. She was seeing her friends, but in a more responsible way. None of the drug use and all that stuff. So fantastic turnaround. And it took only 2 months, 6 weeks. Yeah. But she went through a journey of pain for about 2 years, 2.5 years. Why is this case important? What am I trying to say in this case? This case is important because this young person was going on bridges, was taking overdoses, was very risky, was very suicidal. Nobody could cope with her. Specialist foster carers couldn't cope with her because she was too risky, too suicidal. And the emphasis is on risk and suicide, and people are thinking about managing that, which is a mistake. The priority has to be to manage the underlying causes of stress which make us self-harm. And that's how we need to think about crisis. That's how we try and think about crisis. It's not something that's easily thought about because suicide and self-harm is extremely evocative to the human nature, and we get alarmed, and it's only natural for us to respond and do something. And that's what happens. So what happens is in hospitals, in clinics and assessments, the reaction is let's do something, let's go into a hospital and get admitted. And that's just a harmful outcome. Inpatient hospital admissions for emotion dysregulation is counterproductive, harmful, is not the right course of action. Just you can try and remember that as much as possible. That's a key message for today. So I'm going to go back to what we did in this case, which is what we do in our brief stabilisation pathway. When we do a comprehensive mental health assessment, we identify first, share, and identify the needs first, share the understanding, and we focus on addressing the unmet needs. What are unmet needs? Anything that causes perpetual stress in a child. That could be anything. And I'll list, there's a few things. A lot of these are reversible, so we target reversing the unmet needs. So for example, if you have a young person who's self-harming on a daily basis, and it is discovered that there is protracted physical and emotional abuse, the treatment after that assessment is not therapy or medication, is actually eliminating the abuse. A young person who's self-harming on a daily basis because they're not integrated in school, they're being bullied, cyberbullied, physically bullied on the school on a daily basis, and they're self-harming. The treatment is not therapy or medication, the treatment is go to school, make sure that the bullying is eliminated. There is no two way about it. There's no sort of other way to think about it. So the first intervention is to work on reversing the sources of stress that cause self-harm. What are unmet needs? The big ones, which are hard to pick, is unidentified and unaddressed developmental vulnerabilities. What is that? That's sensory integration difficulties, language or learning difficulty or delay, ADHD, autism, dyslexia. Any of those things will cause more stress to a child, and if they have not been recognised, and the child has to go through academic demands as well as social emotional demands of adolescence, and as well as the physiological changes, for those who are vulnerable, it will become too much. What else? Anything that causes stress, bullying. In looked after children, in young people with disrupted caregiving, a history of neglect, abuse, trauma, they're more vulnerable, and any threats to attachment security is likely to de-escalate and cause more stress and then subsequent self-harm. So if we have evidence of that, again, the treatment isn't to think about therapy, medication, all that stuff. Again, we're going down the wrong path. It's to make sure they have stable caregiving. School refusal, social isolation, there's no point starting medications or therapy. If you have any requests from a 17-year-old who wants to start depressant medication or anxiety medication, and they're basically at home for 80% of the time, not seeing their friends, not going out, your medication isn't going to work. It's not going to work. The effort has to be for them to be activated, go to school, have a routine, see friends, be physically active. Any untreated major mental illness. I mean, that's an obvious cause of suicidality, depression, anxiety, OCD, psychosis, anorexia. In the absence of psychosocial instability, if that is untreated, that needs to be treated. So, just very simple messages. I mean, they appear very simple, but obviously they're hard in practical terms. Unmet needs means stress. Stress means self-harm. Address the needs. We're addressing the risk. So when we see what is the risk management plan, we get asked by social services. And they're often thinking, oh, there is some sort of practical strategies like distraction, soothing, go out for a walk, call someone, all that stuff. I don't write any of that because I think that's nonsense. I write the way we're going to address the needs, but the way we're going to actually risk manage is by actually addressing the underlying needs. And sometimes that's addressing bullying or family volatility or underlying mental health issue. A lot of the times, the cases that I get involved in, it's a combination of three: educational needs, family needs, and mental health needs. So multi-agency integrated care is the only way to proceed. So that's where this pathway comes back. Just to revisit it very quickly. Risk assessments, what do we usually assess? So, can I ask a quick question? Do CAMHS services, for example, in adolescents, do we do risk assessments for suicide? Hands up. Hands up. Do we do risk assessments for suicide? We do. Nobody thinks we do risk assessments for suicide? Really? We do? Anybody else? Actually, we don't, and we shouldn't, and we can't. We cannot do a risk assessment for suicide. That's not possible. There is no assessment method, there is no tool that exists that can tell us the risk of suicide in an adolescent. Okay, but I tell you what, we still seem to do it in CAMHS services. Okay, why is that? Suicide is a extremely rare outcome in adolescence. It's a low population base rate phenomena. So there is no way of assessing suicide risk, and that's not just my opinion. I mean, all the people who write about suicide and suicide risk will say that. I mean, this one was quite interesting. I thought a clinician would actually be correct much more often if he and she predicted that a patient would not commit suicide, regardless of the clinical presentation. How interesting. But that's correct. I mean, suicide is 5.6 out of 100,000 people in the adolescent age group, and amongst all the age groups, that is the lowest prevalence rate of suicide in the population. It is too low to study. It is too low to figure out which child is more at risk of suicide. It's not possible. So in my assessments, that's not something I either comment on or either document, because it's a false claim. If I say somebody is at medium, low or high risk of suicide, it's a false claim. What does low or high mean? Do I mean there's a 10% chance or a 20% chance? We can't quantify it. We cannot have a numerical value against that. The Health Education England produced a competency framework for all services and professionals who are working with adolescents and adults who assess distressed people with self-harm. They've also stated and also highlighted all the references, which says that firstly, risk assessment tools are poor at predicting risk of self-harm or suicidal attempts. They're poor. There is no risk assessment tool that helps us give us an idea about predicting the likelihood. So what we're left with is expert clinical judgment. So clinicians sort of comment. But even for self-harm, which is far more prevalent, the prevalence of self-harm is about 9% in adolescents in the last year, 16% in adolescents in a lifestyle. It's far more common. Clinicians can offer a bit more of a comment on that, but it's expert clinical opinion. These are just some of the risks, some of the references, just highlighting that predictive value of risk scales are poor. So that's not something that should be relied upon by anybody. It's a clinical assessment which is helpful, and you can use this as a supplement. So the answers are we cannot determine risk of suicide. Risk of suicide categorization is really, and suicide cannot be reliably predicted. And this is just the last minute or two, is some thoughts with you guys as to what can GPs do. I'm just going to, because we have 5 minutes for questions. Is that right, Katie?
No, you only have 30 minutes in total. We're running over time now.
We're running over time. Okay, so I'm just going to finish off very quickly. You have this in your presentations, and you also have a couple of resource documents. But I'm going to just assume that you will obviously take a history in your clinic, in a GP clinic, when a young person comes in and talks about suicidal thinking or plans. And I'm going to assume you automatically are going to be thinking about making an onward referral to whether it's counselling or whether it's CAMHS or whether it's asking them to go to A&E. If there was anything else that you could do, it is find more time to talk to the young person, because that is quite therapeutic, quite containing. I don't know if it's actually always ever possible, but does anyone ever do a double consultation for an adolescent if they're not coming in for a physical health issue? Because that's a really good idea. That could be operationalized, because that's quite powerful. But just by showing curiosity, by acknowledging, by validating, by listening, by asking them to come back whilst you do all those things, or even setting a goal, that raises the value of their experience, and that's likely to contain and reassure them. We know this because we've done 3 service user participation groups as part of our service once every year, and young people have told us that. So this is some standard advice, and advice, if you're going to give a young person any advice, it only works if you have established a good enough or a better relationship with a young person. The relationship can only be established if you have more time. Okay? So, and on the basis of that, if the young person likes you and trusts you, they're actually able to follow the advice and come back to see you again. So that's an important one. And you've got a couple of leaflets, and I think that's it. The rest of the presentation, you can read it at your own leisure.